Welcome to an introduction to the RCGP and Marie Curie Daffodil Standards for General Practice teams. My name is Dr. Catherine Millington Sanders and I'm the RCGP and Marie Curie National End of Life Care Clinical Champion. Getting started with the Daffodil Standards. So why use the Daffodil Standards? The Daffodil Standards provide a framework for improving palliative and end-of-life care as well as bereavement support in general practice. Using the standards can help improve your patient and family's care, increase staff confidence, and improve your overall practice performance. Any member of the GP team can lead on a QI project, and whatever your starting level, keep it relevant to your practice, your staff, and your patients because every improvement step counts. Small steps can result in significant improvements. So why are the Daffodil Standards important? Well, one person dies every minute in the UK annually. Up to 9 bereaved people are affected by each death, and most people have a predictable death. 60 to 90% of people in the last year of life have an informal caregiver. And with an ageing population with increasing multimorbidity, palliative care is only set to rise over the coming years. GP teams lead the majority of this care in the community for people with palliative and end-of-life care needs, with only a small proportion under specialist hospice care. GP teams regularly support conversations with people about what matters most to the person and their important others, and this enables consistent personalised care and support planning. General practice plays a key role in the delivery of end-of-life care and bereavement and is ideally placed to reduce variation in care, regardless of diagnosis, age, gender, ethnic background, sexual orientation, disability, or social circumstances. Population health looks at the health of a group of people and how their health outcomes are spread across the group. The quality of end-of-life care and bereavement support significantly impacts the overall health and well-being of people. There are many factors that account for inequalities in end-of-life care and bereavement support, and you know your practice population and are best placed to consider which factors are most likely to affect your patients and also ways your practice can help reduce variation. But to help your practice offer all people who need planned end-of-life care and bereavement support, we need to first identify people with need. Once identified, the next step is to assess and confirm their care and support needs. If you're unsure where to start, an option is to pick one area of inequalities to focus on across one or more Daffodil Standards. If you uncover any differences, this is a great opportunity to think what quality improvement activity you can do to reduce that gap. For more ideas, have a look at the RCGP Daffodil Standards web pages. The RCGP and Marie Curie Daffodil Standards aim to help your whole practice team spot areas for improvement and build on the great care you provide already. The standards are relevant to all UK practices. They can also help you assess and reduce variation in inequalities in care, to enable your whole practice population to get the right care and support for them. How do the Daffodil Standards work? Once you're signed up, you'll receive a welcome pack, including a daffodil mark to display in your practice. Plus you'll receive daffodil updates with free tips, tools and support available to help your work grow. The Daffodil Standards, also known as the RCGP and Marie Curie UK General Practice Course Standards for Advanced Serious Illness and End-of-Life Care, cover 8 core areas. They offer GP teams a relevant self-assessed structure. All the resources are free and online to help you get started, with a blend of quality statements, evidence-based tools, reflective learning exercises, and quality improvement steps to help assess your baseline practice. Standards 2 to 7 follow the patient pathway from identification to care after death. Standard 1 supports multi-professional development, and Standard 8, compassionate organisational development to support both staff and patients. There is guidance for at-scale implementation in primary care networks and also a pack for practice patient participation groups. The standards can be applied to your whole practice population affected by end-of-life care and bereavement, or you can choose to focus on a particular standard of interest or a cohort of people, for example, older peoples in care homes. So where to start? Whatever your starting level, keep it relevant to your practice, your staff and your patients. The most important thing is to start somewhere. Each improvement step counts. And quality improvement doesn't have to be difficult. Small steps and changes can result in significant improvements. Based on feedback from GP teams, we've created a simple 3-level approach that can be applied to any or all of the standards. Level 1, Core Essentials. This is focusing on internal practice systems to enable consistency of your care. This gives you a framework to assess and build on your care learning. Level 2, Enhanced. So once you've assessed your baseline, this next step helps you plan your quality improvement activity based on what you found in your diagnostics. Level 3, Advanced. This aims to support co-production of care and a compassionate community approach. The Daffodil Standards offer several key benefits for GP teams. Practices can work at their own pace, whether on a small or large scale, and gain free access to a wide range of tools, tips and improvement ideas. Any team member can take the lead or participate in quality improvement activities, ensuring inclusivity in the process for the whole team. Teams also have access to updated evidence and resources, making the standards relevant to any practice population while helping you to reduce health inequalities. Peer support networks are also available to foster shared learning, and the framework provides regulatory benefits by offering you evidence of systematic practice improvements. The Institute for Healthcare Improvement's model for improvement suggests we need to answer 3 fundamental questions for any quality improvement project and then use PDSA cycles to test change ideas. These 3 questions are: 1. What are we trying to accomplish? 2. How will we know that a change is an improvement? And 3. What changes can we make that will result in improvement? Let's get started by identifying key steps to improve end-of-life care and bereavement support in your practice. Step 1. Clarify who are your end-of-life care named clinical and non-clinical leads in the practice. They can help support a culture of reflective learning and improvement with discussion within the practice team and supporting change ideas to thrive. Leads are not there to do everything though, it's a whole team approach. Step 2. Share the vision for enhancing end-of-life care and bereavement support with the whole team and encourage everyone to contribute their ideas to this shared goal. Step 3. Consider any learning needs across the team to support these improvements. Analysing your baseline data is key to assessing where you want to focus your improvement efforts and what impact your improvement is having. The Daffodil Standards consider 3 main sources of baseline information. 1. Your retrospective death audit. 2. Feedback from patients, caregivers and patient participation groups. And 3. Feedback from practice staff and MDT members. Keep it simple and remember you don't need to collect data for the sake of it. A quick retrospective audit won't take you long. It will help you identify themes as to where to focus your quality improvement activities. For example, review your last deaths. That's review all deaths, not just people with cancer, people on the palliative care register, or people known to the specialist hospice team, and reflect back on the last 20 of your deaths. Like a jigsaw puzzle, these different sources of information can help your practice build an understanding of your baseline performance across each Daffodil Standard and where to focus your improvement activity. Visit the Daffodil Standards web pages to find out your example audit, MDT and feedback templates to help get you started. Think about what's helpful for you to collect, how often, and how to incorporate data collection into business as usual. You don't have to do it all at once and look out for easy wins. For example, how does your practice code information? Is it consistent? If people have been identified as having palliative care needs, is it clear to the team how to help these patients get easy access to the relevant care and support? And do your MDT processes help facilitate this? Reflect on the results of the information collected, not on your own in a dark room, but with other members of the practice team involved in end-of-life care. You can involve your patient participation group and also your wider end-of-life care MDT and even your primary care network This can be your first peer review meeting, and it's a great opportunity to share and reflect on your audit results, and also to use the wider team to think about potential smart aims and change ideas. What are we trying to accomplish? Start small and grow. Write your smart aim, think about what you can measure. Try and make it as specific as possible. You can always refine your ideas as you see which changes work best for your practice and your patients. There are QI smart ideas for each standards and lots of great resources to help you plan your project on the RCGP Daffodil Standards web pages. Here are some examples of SMART goals. Naturally, the baseline percentages here will depend on your initial assessment, so please adapt them to make sure they're relevant to your unique practice priorities. For Standard 1, professional and competent staff, a SWOT analysis can be done within a set time period to identify your learning needs. Standard 2, early identification of patients. An example goal may be to increase the percentage of people who die having been on your palliative care register. For Standard 3, carer support, an example goal may be to raise informal caregiver identification, or increase number of assessments for caregivers' needs, or increase signposting and referrals for support. Lastly, Standard 4, seamless planned coordinated care, may be reviewing and agreeing on consistent coding for key data items. For Standard 5, the goal may be to increase the percentage of people on the palliative care register who also have an advanced care plan. Standard 6, the aim may be to improve the quality of care during the last days of life, perhaps increasing the proportion of those who died on the palliative care register, having documented the 5 key principles from the priorities of care for the dying person, summarised as CRISP. Standard 7 emphasises care after death, with the goal of increasing condolences and signposting contact with bereaved families. Standard 8 aims to position general practice as a hub within compassionate communities, so running a staff experience survey or a minimum of 5 patient or caregiver experience interviews can offer really valuable qualitative information. How will we know that a change is an improvement? The key to knowing this is measurement. Often we're very good at changing things, but how do we know we are making things better and not worse? Often we think things are better, but to be sure, we need some sort of measurement to demonstrate this. So what will you measure? You may well measure more than one thing. Consider your outcome measures, which could, for example, be the proportion of people dying who are on the palliative care register. You could also measure a connected process measure, such as number of patients reviewed for consideration for the palliative care register. You may also want to measure balancing measures, such as number of additional consultations or home visits each week to do these reviews. Balancing measures look at consequences which are often unintended but happen as a result of you making a change. You don't need to measure all of these, but you do need to measure something regularly to track when you make changes in order to demonstrate improvement or otherwise. And also remember, you don't need to measure all the things you measured in the initial audit, just the things you're trying to change, or that you think may change as a consequence of other changes. Keep it as simple as possible. What changes can we make that will result in an improvement? Brainstorm your ideas. Include as many team members as possible in this process. Your receptionists, GPs, nurses, HCAs, clinical pharmacists, end-of-life care, MDT members. These can all bring fantastic ideas which you'll never know about if you don't ask them. So be as inclusive as possible. So now you'll have a whole load of exciting themed ideas. Next, you prioritise your change ideas. And this great matrix tool helps teams identify ideas that fall into high impact and easy to implement changes, while understanding that some impactful ideas may require more effort and resources, and low impact ideas, whether easy or hard, are likely to be a lower priority for you. Test your change ideas with your first PDSA cycle. In a PDSA cycle, you make a single change, plan the change, do the change, study the effects by making our measurements and reviewing the results, and then we act on what we find. Start small with changes, and where they make a positive change, then expand and embed them to make them business as usual. Otherwise, adapt them or stop them where changes are needed. The process doesn't end there. Celebrate and share successes, challenges, and learning. Whether your change is successful or not, we can all learn from each other's experiences, and this is a really important part of the quality improvement process. Consider Daffodil Standard 1, relevant learning needs for clinical and non-clinical staff, and using a SWOT analysis framework for discussion with staff about any training needs. Explore if these are common learning needs across your general practice peer networks. Continue to encourage a no-blame, active learning culture. Here are some summary tips for successful implementation. This webinar aims to outline how to start using the Daffodil Standards for improving your end-of-life care and bereavement support in your practice. Start by familiarising yourself with the tools and resources available on the website. Consider what your team want to prioritise and assess and move on to identifying areas for improvement, as well as uncovering areas of inequalities. The framework encourages setting clear goals, integrating changes into routine practice and thinking about any necessary resources and training available. It highlights the need for good monitoring, data collection and documentation to track your progress. Sharing best practice and fostering collaboration are important to build team confidence while embracing a culture of learning to sustain your high quality of care. If you've not already signed up to the Daffodil Standards, sign up today and get your free welcome email with everything you need to get started. You'll also get a welcome pack in the post with a Daffodil mark and resources you can display in your practice. All information discussed here and further resources can be found on the RCGP Daffodil Standards web pages. Thank you.